how expensive is this disease, and how expensive is a recurrence, and how much money do you save, because this drug, I'm sure, because it's new, is not cheap. How much money do you save by using a drug which cuts your recurrence in about half, you said?
Well, that's a very, very good question, and the answer is it depends. What do you take into consideration when you talk about money? And if you only take the cost of the drug, you don't save any money. You actually waste
No, but I'm
more
asking
money.
about the cost of society.
But of course, if you take a societal perspective, that should be the perspective we should be taking in such a discussion here. First of all, you save half of the recurrences. So then the question is, how much is a recurrence? We know some people get admitted, some people do not get admitted. We know that an average admission for a patient with C. diff may be up to $20,000, $30,000. In some studies, up to $10,000, but we save all of that. One should also take into account the fact that when you prevent a person from becoming C. diff positive again, you also prevent secondary cases from this person. And this raises the question, how many secondary cases you prevent?
The so-called asymptomatic carriers or spreaders.
This is the reservoir, exactly, right. and you prevent that. You also have to take into account the fact that many people who get C. diff are actually productive people. They work, they lose work, they pay in quality of life as well. And so the cost of C. diff is enormous, and the cost of recurrence has been estimated to be enormous, and half of the recurrence is a big save.
But I think Peter's point is a good one, that one reason why the drug probably hasn't seen more widespread adoption is that it does carry a high sticker price, and insurance companies may balk at that high sticker price.
All right. You know, I've had this conversation with insurance companies, I bet we all have, but I get to do it on television, over and over and over again. They're on the hook for the global healthcare cost of America, right? Not just the cost of C. diff. And shouldn't they be aware of the dynamic here? And shouldn't they be aware of the global cost of recurrence of C. diff? And shouldn't that factor into whether or not they're going to approve this new drug?
Well, I think at least in the Northeast, I come from Boston. I think that payers take a reasonable approach. They do not approve fidaxomicin for everyone, but for patients who are at particularly high risk of recurrence, so patients who are already started on fidaxomicin, they don't really put the obstacles because they see the value in that as well. The problem that we have is actually with hospitals that have a silo mentality and look at the cost of acquisition. But I think that payers are reasonable and they do understand. I think that the obstacle is actually in the minds of many physicians who do not really consider fidaxomicin for many patients who would be very good candidates. And I can tell you that even in our hospital, where there is a very clear paradigm that identify patients who will be at high benefit for fidaxomicin, we still see that we lose opportunities to benefit patients. And I think that physicians should understand that this is one of the treatment possibilities.
You know, I saw this over and over and over again. What strikes me about this is it was the same kind of story in the early days of the statins, which were quite expensive, but we're saving ICU admissions, bypass surgeries, a lot of expensive medical care. And over time, it became an acceptable expense, right? And now, of course, it's generic, but it does take time to penetrate the reimbursement community. Is that fair?
Yes, I think there is also an expectation that antibiotics will be cheap, as opposed to many other medications, and so the cost effectiveness is a bit skewed. But I think what's important is that physicians understand that if they have a patient at a particularly high risk of recurrence, those patients will really benefit from a treatment that will blunt that, even if this treatment may be a little more costly.
Okay, so the appropriate patient for this right now would be somebody at high rate of recurrence, right? Or somebody that's not responding? Who else, or is it all comers? Should everybody get this drug right now?
So, I mean, you know, kind of what Yoav was alluding to, you probably can select out those people that are going to be at greater risk for recurrence. You know, people that are on antibiotics for other reasons that can't be stopped, they're going to be at higher risk for recurrence, and that's an easy to identify population. Age is also associated with the recurrence. So you might be more inclined to give it to that 70, 75-year-old than maybe that 50-year-old who will be at lower risk for recurrence. Immunocompromised patients are also increased risk for recurrence. So there are subpopulations that you could selectively use fidaxomicin to help, you know, balance that cost benefit. They're going to be more at increased risk for recurrence, increased risk for complications if a recurrence occurs. So fidaxomicin would be a good choice.
As well as people who already had an episode of C. diff. So that's important to remember. And when we studied fidaxomicin, we didn't study it in patients who had multiple recurrences, but we did study that in patients who had one recurrence. So they were having their first recurrence, and it seemed to work just as well as it worked. And so this is a very high risk population for additional recurrences.
Okay, well, that's nice. I mean, you know, when you say there's an expectation that antibiotics are going to be cheap, I'm still struck by the cost of vancomycin. I had no idea. Out in the real world, that was expensive.
Well, actually, getting approvals for vancomycin treatment can be just as difficult as fidaxomicin.
Because they're going all the way back to metronidazole?
Well, many times are looking to have the patient treated with metronidazole first before approving vancomycin. So it is difficult, and if you don't have access to the intravenous formulation, which is very inexpensive, then you have to go to capsules.
So it's go ahead and get your irreversible neuropathy, and then we'll consider the more effective drugs anyway.
Well, I
Nice.
think we need to do away with this concept of prescribing an inferior drug first.